Hello everyone, in this video we are going to discuss about clinical anatomy of the lung. So why we need to know this clinical anatomy? Let us see a clinical scenario. A 65-year-old man presents with sudden onset of shortness of breath. On auscultation there is no breath sounds in the right upper chest and we suspect a pneumothorax, that is air in the pleural cavity. So where do you need to place the needle? So to do this needle thoracosynthesis, we have to know the clinical anatomy of the lung. So we know the lung will have the main trachea will be bifurcating into two bronchi, primary bronchi and then secondary bronchi and the tertiary bronchi, where the bronchopulmonary segments will arise, and it have two lungs, the right lung and the left lung. Right lung will have three lobes, upper lobe, middle lobe and the lower lobe. The left lung will have only two lobes, upper and the middle lobes. So the right lung will have a horizontal fissure and a oblique fissure, but the left lung will only have a oblique fissure. So, and in the left lung there is an additional thing, that is cardiac notch is present, and also lingula, that is a part of upper lobe which is just posterior to the cardiac notch. It is additional thing. The bronchi position in the right lung is more vertical, wider and shorter. As we can see, it is more vertical, wider and shorter, but in the left lung it is more horizontal and narrow. Why this is important? Because the foreign body aspiration is more common in the right lung, because it is more vertical, wider and shorter than the left lung. So coming to the coverings of the lung is covered by the pleura. So it is divided into two types, parietal pleura and the visceral pleura. Parietal pleura lines the inner surface of the thoracic wall, diaphragm and the mediastinum. Visceral pleura covers the surface of the lung. So it is covering the viscera. That's why it is called as visceral pleura, and also into the fissures. The subtypes of parietal pleura: costal pleura, which lines the rib; diaphragmatic pleura, which lines the diaphragm; and mediastinal pleura along the heart; and cervical, that is cupula, cervical pleura. And visceral pleura, no subtypes are there. Innervation is by intercostal nerves and phrenic nerves, and viscera receives innervation from the autonomic plexus. So since this is innervation from the intercostal and the phrenic nerves, the pain sensitivity is very, very high. So the patient can localize the pain, and also it will be very sharp. A visceral pleura, it is not sensitive to the pain. Blood supply is by the intercostal and the internal thoracic arteries for the parietal pleura, and bronchial arteries to the visceral pleura. Lymphatic drainage, body wall lymphatics for the parietal pleura, and pulmonary and hilar lymph nodes for the visceral pleura. Embryonic origin is somatic mesoderm, it is splanchnic mesoderm. So why this parietal pleura is important? Because it helps in protection, mechanical support and pain signaling. The visceral pleura it produces the pleural fluid and helps in lung movements. And we have two recesses in the parietal pleura. This helps in secreting, the pleural fluid will be filled within this recess, and also helps in the lung expansion, because these are the extra spaces within the parietal pleura. This is called as recess. There are two recesses, like costo-mediastinal recess and the costo-diaphragmatic recess. These two recesses helps in this. And effusion sites, mostly these collects in the costo-diaphragmatic recess when the patient is upright. Up to 15 ml of the parietal pleural fluid is normal. It helps in lubrication, and also it helps in lubrication. If it is more, then it will be secreted into this recess. Clinical conditions: it is associated with pleuritis, pneumothorax, hemothorax and pleural effusion. And the visceral pleura, it is associated with mesothelioma, direct tumor invasion and also in metastasis. So this parietal pleura is important in needle thoracosynthesis, because it is inserted above the needle should always be inserted above the rib to avoid the damage to the neurovascular bundle, typically at the 8th to 10th intercostal space. Below that, because we have other visceral organs, so to avoid the damage, mostly the needle will be placed at 8th to 10th intercostal space. So next, coming to the bronchopulmonary segments. As we know, the trachea is divided into two main stems, and it is divided two main bronchi, and then divided into lobar bronchi or secondary bronchi, and then into this bronchopulmonary segments. So we know right lung will have three lobes: upper, middle and lower. Upper lobe have apical, posterior and anterior segment. Middle lobe have lateral and medial segments, And lower lobe have superior, medial basal, anterior basal, lateral basal and posterior basal. So we can remember by the mnemonic APA and LM, combining the upper and middle lobes, that is A palm, and lower lobes palms. And coming to the left lung, it will have a lingula along with the superior and the upper and the lower lobes. In upper lobe it is similar, apical, posterior. Sometimes apical and posterior are fused, forming apico-posterior and anterior. So APA same like a right lung, and lingula will have superior lingula and the inferior lingula. So APA IS is the mnemonic. And lower lung will have apical, anterior basal, medial basal, posterior basal and the lateral basal, similar to the left lung. So A palm. So right lung A palm, palms, left lung APA IS and A palm. So through this we can remember the bronchopulmonary segments. So why these bronchopulmonary segments are important? Because each bronchopulmonary segment have independent blood supply. So we have to know this, and we can easily surgically resect these without damaging the other lobes. So one thing which is more important is the relationship of the pulmonary artery to the hilum. In right lung it is anterior to the, in right lung it is anterior, and in the left lung it is LS. RALS, right lung it is anterior, left lung it is superior. So as we know here, in right lung, left pulmonary artery is superior to the bronchus. The black thing is the bronchus. In right lung it is anterior to the bronchi. So each bronchopulmonary segment will have a different these blood supply. Pulmonary artery which carries the deoxygenated blood from the right ventricle, and bronchial artery which carry the oxygenated blood from the aorta to the segments, and pulmonary veins which carry the oxygenated blood to the left atrium. So the oxygenated blood is carried from the aorta to the lungs by the bronchial arteries, and oxygenated blood from the lungs to the left atrium by the pulmonary veins. So next, coming to the clinical importance of all these clinical anatomy of the lung. So first is foreign body aspiration. As we already saw here in this picture also, we can see the right after bifurcation, the right main bronchus is more vertical, wider and shorter. So that's why the foreign body aspiration is more common in the right main bronchus. Next, aspiration pneumonia. When the patient is supine, it affects the posterior segment of the upper lobe or superior segment of the lower lobe. Thoracocentesis, the needle is inserted above the rib to avoid the neurovascular bundle damage, and usually at 8th to 10th intercostal space. So this is the rib, and this is the neurovascular bundle. So to avoid the damage, the needle should place just above the rib. So we have two thoracocentesis. First thoracocentesis, needle decompression. Needle decompression is generally done at second intercostal space at mid-clavicular line. This is for the tension pneumothorax. But needle thoracocentesis done at 8th to 10th intercostal space at mid-axillary line to drain the pleural effusion. Next, bronchopulmonary segments, as we know, the function is independent, and they each have their own independent blood supply, so they can be surgically removed without disturbing other lobes. Pankos tumor, because since a apical lung tumor, it will compress the brachial plexus and also the sympathetic chain, so Horner syndrome occurs. Tension pneumothorax is nothing but air in the pleural space. Whenever there is air in the pleural space, what happens is generally a lung needs a negative pressure to expand. So this will disturb this negative pressure and leads to shift in the mediastinum. The expansion will not be occurring, there will be shifting of the mediastinum. Here the left lung pneumothorax is there, left sided, so it is shifting the mediastinum to the right side. So this will compress the inferior vena cava and decrease the venous return, and patient will have hypotension. Next, pulmonary embolism, usually from the deep vein thrombosis, blocks the pulmonary artery branches, leading to ventilation perfusion mismatch. Auscultation, lower lobes are heard posteriorly, upper lobes are heard anteriorly. This is because of this anatomy, because lower lobes are placed more posteriorly and upper lobes are placed more anteriorly. Pulmonary, in fact, dual supply is there for the bronchopulmonary segment. So because they have both pulmonary and bronchial artery, so these dual supply will protect the lungs. So infarction is rare in these cases, but can occur if both the pulmonary and the bronchial arteries are blocked. Lymphatic drainage will cross the midline. So if the patient is having right lung tumor, it can spread to left lung. That is the importance for the lymphatic drainage. So as we know, chest tube is inserted at the mid-axillary line, 4th to 5th intercostal space, just above the rib, to avoid the neurovascular bundle damage. Cough reflex efferent is via the vagus nerve from the lung, larynx, trachea and the bronchi. So this is the clinical anatomy of the lung and its clinical importance. So we have to know the clinical anatomy. Main points are the foreign body aspiration is more common in the right lung because of the bronchus position, which is vertical, wider and more shorter. Bronchopulmonary segments important because they have independent blood supply, so we can resect without disturbing the other lobes, surgically resect. The pulmonary artery is anterior to the bronchi in the right side and it is superior to the bronchi in the left side. We can remember by the mnemonic RALS, right anterior, left superior. And coming to the thoracocentesis, 8th to 10th intercostal space, mid-axillary line to drain the pleural effusion. Needle decompression in emergency, tension pneumothorax, mid-clavicular line, 2nd intercostal space. And chest tube drain insertion is at the between 4th to 5th intercostal space to drain the fluid at the mid-axillary line just above the rib.